A very good day, ladies and gentlemen, and welcome to the EUPATI Webinar 5, Informed Consent for Vulnerable Populations. During this presentation, your lines will remain on listen only. If you do require assistance, please key *0 on your telephone and a coordinator will be happy to assist you. You may also submit web questions throughout the presentation by clicking on the Q&A tab indicated by a question mark sign. Type in your question and send to all panelists, and these questions will be addressed in the Q&A session. I would also like to advise all parties this conference is being recorded for replay purposes. And now I would like to hand over to your host for today, Luda de Wolf. Please go ahead, Luda.
Thank you very much. Welcome everybody to this webinar. I'm very pleased to let you know that we have actually more than 40 people online plus another 40 on audio, so that brings us up almost to the 100, and people are still coming in. So my name is Lode de Wolf. I work at UCB based in Brussels, Belgium, where I have the role of Chief Patient Affairs Officer, which means that my primary role is to make sure that we work with the interests of patients in mind first and foremost all the time, whatever we do. Today's webinar, organized graciously by EUPATI, is about informed consent, but not just informed consent in general, but informed consent of vulnerable populations. We have an eminent small group, but of very complementary experts online for you who will give you their take on this topic. Before I do, I want to tell you, everybody, we are recording this webinar. We will have both the audio section as well as the slides available to all of you as of next Tuesday, so not tomorrow, but the 29th, to stimulate you to also ask questions, because you will see we have a lot of questions time built in. Please know that the Q&A time will not be put online, so do not feel held back because you think your name would come on Tuesday on the web. The Q&A time will not be shared. It is just the presentations and the audio of the presentations that will be shared. So with that, let me introduce you to the agenda. As you can see here, we are together now for the next hour and a half, and I will try to really finish by my slot because I don't want to take precious speaker time. We have, as I said, very good speakers. I go quickly through them, and I will use both alphabetical and gallant order, which means ladies first. Andrea Heckenberg is really an expert when it comes to reviewing protocols. So she's at the receiving end of the proposed informed consents as well as the protocols. She has been doing this for several years in one of the largest ethics committees in Europe, which is at the University of Vienna. And just to give you an idea, this ethics committee manages and reviews in a year over 1,200 new projects or protocols for that, which is, of course, more than 100 per month, and about 20% of these are actually clinical trials. So we can truly say that Andrea is extremely experienced in looking at the informed consent as a very important part. The second person that we have on is actually on the last of the program in alphabetical order. Next lady is Adriana Cecchi, and I hope I pronounced that correctly, who used to be professor of pediatrics at the university in Bari, Italy. She's an expert in regulatory science and in pharmacology in different fields of medicine, and she actually also teaches this at several courses, the specialty of regulatory sciences, and also even a master on that. So she will really be the expert from the regulatory side, not from the reviewer side. Our third speaker is Joanne Jordan. Joanne represents also EUPATI, as you can see, our gracious host here. And Joanne brings in the receiving end of the information on informed consent, because she has a lot of experience on that side. Not only is she living herself with a chronic condition and has, as such, participated in clinical studies, she's also the mother of a child who lives with a chronic condition, so she also takes the care perspective. And why this is very important is because, as you know, children were the first group of study participants recognized as a vulnerable population. Last but certainly not least, we are honored to have Professor François Lemaire with us today. He has been, for many years, heading the emergency department of one of the main universities in Paris. And although it's not on his CV, I know from my friends that at that time this was considered one of the best and most productive when it came to research also services in the country. So he's actually been doing it from the clinical trialist side. But since his clinical time, he has remained very actively involved, and he's been both involved in the creation of what is today Europe's regulatory framework, which is the new regulation, and he still continues to work on it as he is still an advisor to the French government on the translation of that legislation into French law. So I hope that you will agree with me that we have the very best and complementary speakers panel for you. One last thing I would like to say is that the concept of vulnerable populations, which is today's topic, has indeed evolved. Originally, about 20 years ago, we were only thinking about children as the vulnerable population, and that was later expanded to those who could not consent themselves. Since then, we've realized that the elderly are a separate vulnerable population, and a rather new emerging vulnerable population to which all speakers will also make comment is pregnant ladies. We have about 5 million pregnancies in Europe every year. Many of them could or should participate in clinical trials, and so we will cover that too. Thank you very much again for being here. It is my pleasure now to hand the floor to Andrea, and I will pass her the baton by making her presenter. Thank you.
Thank you very much, Lode, for this very nice introduction. I'm trying to change my slides. This is the way. Sorry.
I can do it for you if needed,
No,
Andrea.
it's okay, but it's somehow, let me, can I just, yeah, now it works. It didn't work, yeah. Now it works. Okay. Yeah, sorry, starting again. Thank you very much for a very nice introduction. I'm going to give an overview of the changes and adaptations that will happen from the CT Clinical Trial Directive, which is in effect right now, to the Clinical Trials Regulation 2014, which will replace this directive. Concerning the inclusion of minors and pregnant and breastfeeding women in research on medicines. First, I would like to say a few words to the informed consent form in general. This is, as we know, supposed to be the main document that helps potential participants for a clinical trial to decide whether they should participate or not. It should inform them on the trial, on the benefits, the risks, their rights, data confidentiality, and so on and so on and so on. As many of us know from experience, this is very frequently not very satisfactory. Informed consent forms tend to be lengthy, hard to understand, not to the point. Whoever has ever read one of these forms knows what I'm talking about. So, how does the Clinical Trials Directive, that's still in effect right now, address this informed consent form? As a matter of fact, it does not really talk about the informed consent form. It states that written that a participant to a trial has to agree in written form, and I think somewhere it also says that information should be written. The word informed consent form, the notion informed consent form, does not appear in the directive. The regulation has changed this a little bit, or quite a bit. First of all, there's now definitions, which I'm not going to show, about what should be contained in an informed consent form, but it also states, and that's a very welcome statement, that this information should be concise, clear, relevant, and understandable to a layperson. How much effect this is going to have, we'll see, but in any case, it's an important statement. This, of course, concerns any concerned in any informed consent form, but especially where minors are included in a trial, it has special importance. Now, to the inclusion of minors in clinical trials. Minors represent a especially vulnerable population which needs special protection, which does not mean, on the other hand, that they should be excluded from the benefits of medicine and from research on medicines. One cannot assume that minors are simply small adults and a medicine tested in an adult will have the same effect on the minor, owing to different metabolism, the growing organism, etc. Furthermore, there are diseases and illnesses that especially occur in the population of minors. So if you test drugs only on adults, it will have the consequence that minors are exposed to medicine that have never been tested in their population. Still, a large amount of medicines that are used in children are not really tested for this population, are used off-label, so to say. This fact has been recognized, as Lode already said, for quite a long time, and the Clinical Trials Directive 2001 already states that children represent a vulnerable population, they are different from adults, and it is important to perform research on medicines on their age group. There are also already the basics laid down on when can a clinical trial be performed in a minor, under which conditions. This has not changed a lot in the clinical trials regulation. Again, I'd like to point out also the regulation 1901-2006 that came into effect in 2007, which and due to this regulation, it is now mandatory if you apply for marketing authorization for a new medicine to include a pediatric investigation plan and also data on this plan. If you look at our studies our medicinal product studies in our ethics committee shows you that since I have here the data from 2009 on, and you can see that the percentage of studies in minors is about 6 to 10%. It fluctuates a little bit. This is very much in line with the general numbers in the EU, as far as I know. Well, even though the basic rules for including minors in trials have been laid down in the directive, there are a few changes or clarifications that seem important to me in the new regulation. The one is the focus on self-determination and autonomy of the participating child. Now, minors are per definition not legally able to agree to participating in a trial, which a grown-up, a legal representative, parent or other legal representative has to agree, but this does not mean they should not be involved in this decision. If we look at the Clinical Trials Directive, there are some, in my opinion, rather vague wording. It says the informed consent of the parent has to be obtained and that must represent the minor's presumed will, and the minor has to receive information according to his capacities of understanding, and his explicit wish should be considered. This is, I think, much better worded now in the regulation. Sorry, I went back. In the regulation, it says that the minor has to be informed in a way adapted to his or her age and mental maturity. and that the explicit wish of the minor to participate or refuse is respected by the investigator. I'm not going back. You got the slides. I think this is a much wording that is much more to the point. Adapted to age and mental maturity means you have to have different informed consent forms depending on the age of the child. Mental maturity, in my opinion, means also that a child with a chronic disease will probably be much wiser regarding the topic than a child that's always been healthy, so this can be respected too. Again, emphasis on the self-determination, autonomy of the minor. And one important point that's also included, that hasn't been included in the directive, is that once a child becomes of age of legal competence, while in a trial, it has to re-consent. This will be important, especially in biobanking studies that have a biobanking part where samples are stored. Once the child is of legal consent age, it will have to consent itself for storage of these samples. There's also a clearer definition of benefit and risk, of the benefit that has to be gained from the study and who has to gain this benefit, and the acceptable risk. The directive says that you can include a minor in a clinical study if some direct benefit for the group of patients is obtained. So it doesn't have to be the child itself, but it has to be the group of patients it belongs to. And then the risk, in my opinion, again, a very vague definition designed to minimize pain, etc., etc., leaves a lot for interpretation. The regulation, as far as the benefit is concerned, it said, if you remember, I may go back once more, there had to be now there has to be a benefit for the group of patients. And here it says a benefit for the population represented by the minor, which means it does not have to be the group, the patients. You can interpret the population as the population of children in general, which means there is a possibility of including healthy children, provided you have minimal invasive procedure, which can be important. For instance, drawing blood for biobank from healthy controls, or drawing blood from healthy siblings of a child with a familiar hereditary disease. And also the risk is better defined, because it tells you now minimal burden and risk in comparison with the standard treatment of the minor's condition. Why is this important? Because some treatments are very risky, if you think of cancer trials. So you don't have low risk there or low burden, because the procedure itself, also under standard conditions, not in a study, will be risky. Those are clearer definitions, but one thing is really new in this regulation, will be new, and that's the idea of the low interventional study. The idea is, if you have a study that poses minimal risk and minimal burden and just uses well-established procedures, you should facilitate these studies. For instance, comparison of two well-established regimes. You should facilitate this by somehow loosening the burden of regulatory requirements. These studies will be facilitated, and as we have heard before, children, this is, for instance, very useful in cancer, in childhood cancer studies, where people look for an optimized therapy by comparing different standard treatments. As these treatments will usually be off-label, because most of the medicines in children are off-label, it is very important that this low interventional, the definition of this low interventional clinical trial is not only, so there are several conditions. One is the medicinal product has to be authorized, and it has to be either used within the terms of marketing authorization, or it has to be evidence-based and supported by published scientific evidence. So the low interventional trial can also be performed in off-label use. This will facilitate greatly for instance, therapy optimization studies in childhood cancer. Now, the inclusion of pregnant and breastfeeding women, as Lode already said, medical studies on children are on the way for a long time already. This is not the case with pregnant and breastfeeding women. Up to the 1957, the marketing, when thalidomide came on the market, it was basically no concern was given to what happens to the unborn child in the mother's womb. It was thought that whatever medicine the mother takes, the child will be safe and a universe of its own. With the thalidomide catastrophe, this notion changed and the attitude changed 180 degrees, which resulted in complete exclusion of pregnant women from all medical research. With the consequence that basically all medicines that pregnant women take now are not systematically studied in their group.
And Andrea, this is Lode.
Yes?
We have about a bit more than 1 minute. Can you kindly wrap up? Thank you.
I'll be quick. Okay? Yeah. So women, about 90% of all women take medications during their pregnancy due to minor or major health problems. And most of these or all of these medicines are off-label. So there is an urgent need for better data or for systematic data on pregnant women. Sorry, I'm going back. There are data, of course, valuable data from registries, from all kinds of data collections, but there's no such thing as a systematic research in randomized clinical trials. If you look at the clinical trial directive, the word pregnancy or pregnant isn't even mentioned there, and that's the big and important step in the clinical trials regulation, that pregnant women are now considered a vulnerable group that can be included into clinical research. I have to be quick, is that correct? Also, the definitions are laid down on how pregnant women can be included in trials. The conditions, I've just listed them here for completeness. I'm not going to go through them. They are pretty similar to, in a way, pretty similar to the conditions of including other vulnerable groups, which is to say that the results can only be reached if this group is included, and of course special protection, etc. In conclusion, there are a few very important things, I think, as far as the inclusion of minors and breastfeeding women, pregnant and breastfeeding women is concerned in medical research in the new clinical trials regulation. One, the emphasis on quality of the informed consent form, the increased recognition of autonomy and self-determination of the minor taking part in a clinical trial, better definitions of acceptable risk and benefit to be gained in clinical trials on minors. These 3 points are basically clearer definitions. A very useful new tool is the low interventional trial, which will facilitate therapy optimization studies, also in off-label use, very important for minors. And then a very big step, finally, the inclusion and recognition of pregnant and breastfeeding women as a potential participant in a clinical trial on medicines. Thank you for your attention.
Thank you very much, Andrea, for a very comprehensive top-line overview of the 3 key vulnerable populations and for noting the progress in that area. I would like now to open it up for questions. We have at this point not yet received question from the audience, but please do feel free to raise it. To make it easier for you, we have actually enlisted the help, as I said before, of Joan. And so I'm going to give the floor to Joan to maybe help us break the ice, because we would really like this to become interactive. Joan, would you like to raise a question on this presentation?
Absolutely, Lode. Thanks, Andrea. That was really, really interesting. My first question would be, really, because I myself participated in a clinical trial when I was of childbearing age, will the children born to pregnant women who participated in a trial be monitored throughout their lives?
Well, I don't think so. I don't think that would be part of the clinical trial because, first of all, it's rather not feasible that you have a trial that goes on for 20 years, or 20 years or more. So I think that would be the topic of a follow-up study later on, but it will be very valuable to have these follow-up studies because then you will have children that were born to a mother who took medicines, who was in a clinical trial during her pregnancy. So you will have very valuable data because they are much more systematic than what you have now from registries and so on. So longer monitoring would be part of a different study, I would assume.
Okay, thank you. And another question I had, Andrea, is on the informed consent form.
Yeah.
What would you say would be the optimum length for an informed consent form? Because you said they can be quite lengthy.
Well, that does really depend very much on the informed consent form and on the study. We have sometimes rather lengthy forms that are excellent. And then we have short ones that are terrible, and there's everything in between. The important thing is that it's very clear and very well structured, that the person who reads it really can understand what's happening, what the important points are, etc. The length nowadays usually does not come from because things are so well explained, but because it's filled with information about side effects and liability things and so on. So the length is not really the issue, I think.
It's the quality, really.
Yes, the structure, the emphasis, yes.
Okay. Andrea, I have a question received via the chat, and thank you for that, Susna, for making the first question. Others, please follow this example. The question is the following. What is your evaluation of the age from when you should involve the child? Yeah. Which is the age of legal competence? So from what age do you start applying this?
Okay, well, the age of legal competence is country specific. In Austria, that would be 18 years. And up to the age of 18 years, a legal representative has to sign the consent form, and the participant can only assent. This varies, I think, from country to country. You asked me about the minimum age, right?
Yeah, it's more the bottom side, from which.
Okay, well, that will have to be. I mean, what we usually say when we receive the informed consent forms for evaluation, we say, well, written information and written consent should not happen before a child cannot read without any difficulties. And that would be probably the age of 7 or 8. And then it would have to be a very simple text, of course. So that is certainly a definite lower limit, in my opinion. Also, the other thing is that a very young child, I think, should not be overburdened with the pressure of having to decide. There is certainly an age where a child cannot and does not want to decide, and that would put a unfair and very stressful responsibility on him or her. So our rule is 8 years. Of course, children with a chronic disease and living with this disease, maybe from a very young age on, are maybe you could ask them earlier on. That depends on the situation and the child, I would say.
Okay, thank you very much, Susan. I hope this answers your question. If not, please come back to us. I have no other questions. So, Joan, I think we back on relying on you.
Okay. I had a question I was wondering about for vulnerable populations. How are the side effects monitored in comparison with regular clinical trials, Andrea?
Well, this is I'm not exactly sure, maybe somebody else can say something, but I think the monitoring of the side effects does not depend on whether it's a vulnerable population or not. The decision is on the inclusion. When can I include a participant that belongs to the vulnerable populations? Yeah, those are restricted. I can only do that when I cannot answer my research question without including him. But I mean, extra monitoring of risks would mean the other not vulnerable population gets less monitoring of risks. I do not think that is the case. Correct me if I'm wrong.
No, I don't think so. Adriana, you also joined us to help stimulate discussion.
Yes.
Would you have any specific question?
Yes, I would like to come back just to question the legal competence age. That is a really important point, and I agree with the answer given by Andrea, of course. My question is, do you agree that we should concentrate not only on the legal competence, but on patients' capacities? That is not linked to the rule or to the national legislation, but just is linked to the judges or the people around the children.
Mm-hmm. Mm-hmm.
So, what do you think in particular with the recent proposal to set up young patients advisory groups to help this process?
Can you repeat the last sentence?
Yes, currently there are initiatives also supported by the EMEA to create young patients advisory groups.
Okay.
Yes. What is your opinion on this?
Well, first of all, I think you cannot. The legal age for consent, I think that's out of our hands. I think it will. There will always be when in a certain country the legal age for consent is this and this, you will not be able to change that. But of course you can. This does not prevent you from personally or from really involving the adolescent as much as possible in the consent process. And it is also said if the adolescent does not want to participate, regardless what the parents say, he doesn't have to participate. I think this legal issue we cannot get around, but of course it should. Of course you should respect the maturity of the child. You can only do this on a case-by-case basis by looking at the informed consent forms. And yes, of course, I think it's very valuable to use the support of this. I forgot how the groups are called. Any input from these people will be very valuable because they see it from a completely different perspective and maybe notice things that the doctors and also the ethics committees and so on do not observe because they look at the study from a very, very special point. So any private or any extra initiative is very important and very welcome. But the consent will have to be according to legal conditions, I think.
Andrea, this is Loda again. We have another note that says also from Susna that in cancer there are actually even teenager patient organizations, so teenagers with cancer, just pointing to the fact that sometimes a chronic disease or acute disease can make you much more mature, force you to be mature. Yes. I have a question in this regard. It's very clear to me when, for example, the parents consent but the child says no, that the decision will be no. What happens in the opposite case? The parents say, no, we don't like you to participate in the study, but the child, teenager or not, says, yes, I want this. What would happen in your case with the review of such a situation? Have you ever had it?
Well, we have never had that. I believe I've heard of cases where parents, for some religious or other reasons, didn't want their child to be treated and I think in this case there can I'm not even sure. I think this child can get a legal representative and go to court. That would be treatment, life necessary treatment. I do not know. I've never heard of such a case. I do not know, I must admit.
Okay.
Is this, have you ever heard any? Is this really? Does this happen?
Well, having a 15 myself.
A point. The question is when the opinion of the legal representative of the child diverge, which should prevail? This is the point. Because I think that the pediatric regulation and also the last clinical trial regulation is going in the direction that the opinion of the child should be absolutely respected. So at the end, we should be very, very careful when a child refuses, in particular when it is an adolescent. This is a very complicated aspect, I think. How do you address this point? How do you face with this?
Pardon the last sentence again?
How do you face, for example, in an ethics committee with this problem?
I can only... this is not... I don't think that would be a case for the Research Ethics Committee, actually. What we do is we review the documents and whether they are suitable. Those special cases, would they come before the Research Ethics Committee? I doubt it, actually.
Actually, that's a very good point, because we have to make the difference between the review of the study and the informed consent for it, and then the actual individual consent process for each potential participant. So I agree with Andrea. In my experience, that discussion would take place in the clinical investigator setting, yes. And only when they find no way out, then there could be other avenues, but it is not specifically something that goes to the ethics committee.
Mm-hmm. But this is not my experience. For example, in ethics committee in Italy, usually informative for children and also a kind of guarantee regarding the type of information we are given to children is requested. But I agree with you, it's not officially an issue for the ethics committee. I completely agree with you.
Okay, we have a little bit more time, so otherwise we will move forward. But a last call to all the participants. You've been very good listeners, and very few of you have been good challengers. So use the opportunity. You can speak up and ask a question. Even the power of silence has not made you change your mind. That's fine. I can only conclude from that Andrea, you have been extremely clear in your overview, and I really want to thank you for that. So I'll turn maybe one last time before we go to the next topic then to Joan or to Adriana. Do either of you have another burning question for Andrea?
This is Joan. Andrea, I'd just like to ask you, what would you say is the biggest advantage of introducing this new legislation compared to the old legislation?
Well, it's hard to say yet because it's not in effect yet. But one of the reasons this regulation will take effect is that it is trying to speed up the evaluation process for application of a clinical trial, and that the stringent timelines have been introduced, and you only apply at one portal, and you only have one body per country to evaluate the application of the study, which this body consists of a combination of the ethics committee and the competent authority. So that's One of the things they had in mind when they did this regulation, I think the low intervention trial is a very good thing because it really will facilitate research important research with minimal burden and minimal risk. And I think, of course, like the introduction of pregnant women as a possible vulnerable group, that can be included into medical research is a very big step. So that's the first things that come to mind.
Thank you.
Yeah, Joanne. So I'd like to take my privilege as moderator to also try and answer your question by adding on to what Andrea said, and which I fully support, which is that specifically for the newest vulnerable population, which is pregnant women, this new regulation for the very first time even talks about them. And by doing that, we actually start breaking the taboo. You have to know, everybody on the line, that for many years, women, pregnant or not, were excluded from clinical trials because it was just too difficult to deal with the menstrual cycle and with maybe pregnancy and all of that. And unfortunately, that has now changed, and there's an ever stronger call to have good gender balance in there. But at this time today, still, most people, investigators and sponsors, as well as regulators, used to kind of not even want to talk about pregnant women. And as Andrea said, 90% of all of us have been exposed to drugs in the womb of our mother. And so we owe it to society to start addressing this. And for the first time in history, we now have a legislative framework that doesn't force it, but that really mentions it so many times and has even a specific paragraph on it, Article 31, that it basically tells everybody, we expect this to happen. If not now, then very soon. And that is a huge step forward, I think.
Great.
If I may add something. May I add something now at that point?
Please.
Yeah, I'm François Lemaire. Another good innovative item in this regulation is introduction of research in emergency situations. Maybe not as important as a pregnant woman, okay, but the Directive 2001 did not consider the waiver of consent during emergency research, and so it's another good point of that regulation.
Excellent. Thank you, Francois, for this very important addition, because indeed that was a totally unserved area where you could make a lot of difference and add value to patients. So with that, I would like to close the first part of our webinar, and we are now going back to Francois, who just made the comment. And so, Andrea, if you could please, it's already done, hand the slides to Francois. Francois, the floor is yours for at least the next 15 minutes. Go ahead.
Yeah, I need my slide probably.
All right, let's move forward.
Okay, here they are. Thank you. I need the next one. I don't know. Okay, as already told by Andrea, it's clear that the cornerstone of any research on persons, on human beings, is the informed consent. It is simple, it is really obvious. But now, when the people, the person, the patient cannot consent, what to do? There are only two possibilities. The first one, of course, is stopping doing research, accepting to deny the benefits of research to the most terrible diseases usually. Or society and legislators, more than patients themselves probably, need to accept some compromises. A full consent is not always possible, but you cannot deny the benefit of research. So you have to accept that the consent could be given by another person than the patient himself or herself. And sometimes even no consent at all can be accepted before starting a trial. But obviously, there are some counterparts of that, and security has to be increased for those vulnerable patients. I don't know how to proceed. Yeah. Just look at that slide. It recalls a trial made more than 10 years ago by one of my colleagues, Jiali Anan, who published a study done in patients in septic shock. Septic shock is a terrible disease or syndrome with a 50% mortality. And at that time, it was not possible to waive the consent. So the patients were unable to consent. And so when that trial started, you can see on the bottom of the slide, I don't know if you see my pointer is, is it visible elsewhere than on my screen? Do you see it? No, you don't see the arrow? No, okay.
No, we don't. We don't,
No.
François.
Okay. The dotted line, which indicates the expectation of recruitment, because the x-axis gives you the dates starting from 1995, going for 4 or 5 years until 96. And so that line indicates the rate of inclusion. If you see the other line with big black points, you can see that only half the predicted patients were able to be included. And so continuing on that slope, the trial would never finish. And at one point, the ethics committee, which was solicited, did accept that the consent was waived for that study. And you can see that immediately the rate of inclusion increased and the actual slope was identical to the predicted one, and that trial was finished as expected. And it was good because it was the first trial on a new drug on that terrible condition. So it was pragmatic to see that only in that case the trial could be completed by waiving the consent. So we consider here two different situations. The first one is the patients who are incapacitated, but not necessarily under emergency situations. To give an idea of what it means, I give you some first scenario. You consider a patient, young patient with an infectious disease due to a virus with some type of encephalopathy, which means he is in coma. So it cannot answer any question. Of course, it cannot be informed on the trial and obviously cannot consent. And so if you want to test a new drug on that patient, how could you do? You need that someone else gives the consent for him. But to accept that, the legislation gives a lot of conditions. And all the conditions I will give you here are in addition to the more global conditions. Some of them have been explained already by Andrea. So all those are additional conditions. For the beginning, for basic conditions, the subject should not have opposed a trial before, which is a bit theoretical because you never know that, obviously, if the patient is unable to speak for himself. More importantly, you shouldn't have a national rule which could prohibit such a trial. Usually, the European law has a value superior, higher than the national ones, but not in this case. If it's not possible to do that trial in your country, there is no way that Europe would force you to do it. Of course, some consent should have been given and signed by some legal representatives. That concept have already been defined by Andrea. You have to know, besides pediatry, of course, you have to know that that legal representative is a concept defined by the national laws. For instance, in Spain, there is some hierarchy which is given. You should ask consent first to the husband or the wife, and then the children. Then, in France, it's different. In France, which comes first is a person designated by the patient himself when he was able to do it. In Germany, I've been told that legal representative is a person who is designated by a judge. Probably not very convenient way. I don't know if it's still valid. So anyway, for those patients, you need to have an informed consent from somebody else than the patient itself. As in pediatry, the patient who has some partial level of conscience should participate in the trial. Honestly, I've never seen that before because the conscience certainly is going from 0 to 100% as a spectrum, but the consent is yes or no. And so I understand that provision, but I'm not sure it's very practical to use. As a general rule, of course, no financial inducement. The trial cannot be performed in person able to consent, which sounds a bit strange, but can imagine an investigator doing a trial on, let's say, cancer, leukemia, and he could prefer to use only patients unable to consent because he could think it's easier for him to do it. So, of course, that is not acceptable, and that's why the trial should be restricted to the same person. And, of course, trials relate to the medical condition the subject suffers from. Again, imagine a patient with, let's say, a stroke. There is no way to test on him a new drug on the kidney cancer or liver cancer. It's common sense probably, but it's better if it is written. And now the complex problem of the risk-benefit ratio. But it's fortunate for me that Andrea explained that already. For children, it's basically the same concept. You have two different cases. If that trial is expected to provide a benefit, a direct individual benefit to the patient, it's okay. If the benefit is higher than the risk, it's not so easy to evaluate, I'd say mathematically, that balance. It's more a concept. But you need to have an expected benefit greater than the risk. But sometimes you have another situation where that trial is not supposed to give a benefit to the individual patients. Let's think of the cognitive trial, for instance. The patient himself will not benefit for it. In that case, as in pediatric, the trial should provide a group benefit, which means a benefit to the global population of the same patients, the patients with the same disease. Let's say in terms of knowledge improvement or a better prognosis, for instance, for that population. But in that case, the trial should pose only a minimal risk. But again, it's not an absolute value minimal risk. It's a minimal risk by comparison to the usual situation, the standard treatment, which is a very important restriction. So let's move now to the emergency. As I said before, it was not that situation was not considered in the directive of 2001, which was really, really regrettable. But now it's done. So what is emergency situation? Let's look at that scenario 2. Imagine a 60-year-old man suffering from a stroke. When he's walking in the street alone without his family around him. So the ambulance will drive him to the hospital, to the emergency department, and in that place there is a trial going on a new drug which is able to dissolve the clot in his brain or in his brain's arteries. And so the patient cannot consent because he's, in this case, in a deep coma. And the family is not there to consent for him. So what should we do? The legislation now accepts that in that case, a very specific case, the trial may be started without any prior consent, which is a bit strange, or I mean a very, very serious restriction to the usual concept of consent and research. But of course, there is a lot of precautions, a lot of obligations, and we can go through that list. The first one, of course, you need to suffer a last training situation, of course. Now, in that case, there is a reasonable expectation of direct benefit. So maybe we'll discuss that a bit later because it's a really a tricky concept that necessity of a direct benefit. Maybe I will tell you later what it means. Then, the legally representative is not there and is not expected to be there within 1 or 2 hours, for instance, as is my case of the new treatment on stroke. And so he's not there, he's not coming, and so you could start research without waiting for him, for that person. Again, as we have seen before, the investigator is not aware of patient's objection. Again, I don't know how he could know that, but okay, it's written this way. Now, this is a problem. The trial relates to the condition which makes consent impossible. So it's a problem because imagine that in intensive care unit, the patient is there, already there, and there's a sudden occurrence of a new complication, new disease, for which you want to do some research. But the patient is, as it is nearly always the case in intensive care, the patient is anesthetized. So if you read that sentence, it seems to indicate that you could do research in that case only on sedation, because it is sedation which makes it impossible to consent. This was explained to the Commission during the discussion when the regulation was drafted, but it was impossible to change it. So it is the way it is. But probably it means nothing. Condition 6 now means minimal risk again, but as it was before, it's minimal risk in comparison with the standard treatment. It's not a minimal risk by itself. Again, it's important if you do research on, let's say, a huge event like a stroke, the risks of the disease, of the usual treatment are already very big. And so minimal treatment means nothing. Only minimal risk added to that risk due to the disease and the standard treatment. So that wording in this case is excellent. Now, you have started the trial. The patient is still there. And after a couple of hours, couple of days, the patient may recover consciousness, regain consciousness. And if you want to continue the trial, if it's not finished, you have to ask him to consent. And if another person, a member of family, comes before the patient regains consciousness, you have to ask him to consent. So it's called a secondary consent. Next. So these are the conditions for doing research in these two situations, incapacity and emergency situations. using that, a lot of research has been done in the last 20, 30 years in those terrible diseases, like those we see in intensive care units. And I conclude by that slide giving the results, not of one study, but of one group, a group of Milberg working in Seattle in the U.S., who treated during 10 years, you can see the time scale on the x-axis, during 10 years, a syndrome called the acute respiratory distress syndrome, which is a terrible disease. And during the late 70s, beginning of 80s, when it was first described, mortality rate was 90%. And you can see in that slide, which I repeated, the experience of one group, but which corresponds to the worldwide experience. During 10 years, you can see that the mortality rate on the y-axis decreased steadily from 70 to 35%. And this corresponds to the actual prognosis in that syndrome. And of course, you can imagine that it's not simply by looking at these patients, treating them on the best they could, that physicians could obtain such a result. It was done because they have done hundreds of trials in that situation, and probably involving, I'd say, thousands of patients all over the world. But believe me, not a single one of these patients was conscient at the time of the trial, and the consent was only given by the family or waived. And it's only because of that, I'd say, exception in the legislation that such progresses could have been done. But thank you for your attention. I am ready for questions now.
Thank you very much, Francois, for an excellent presentation of indeed a very precarious situation that all of us could find ourselves in one day, not even by our own choice. Florian asked a question online. I don't know if Florian has access to the microphone. So, Florian, you want to ask it? If you don't, I will do it. There's a silence there. So the question of Florian's was one that I also had. In your second case, the case of the 60-year-old man who has a stroke and is transferred, you actually described the case as the choice between placebo and drug. And whereas we both could agree that the decision to give him this new drug would be something that we would be comfortable with, the actual chance of getting placebo, i.e. not the existing fibrinolytic drugs, would be something that we want to challenge. And I see now a note that Florian is on the phone, so maybe, Florian, you can add a few words? You have to unmute? Okay, that's not... No, we cannot hear you, Florian. Francois, why don't you start answering?
Yeah, I can start answering that. Yeah.
Yes.
Well, it's a terrible question, and it goes to that concept of direct benefit. It's why I waited to comment on that. How to start in that? The concept of a randomized controlled trial is well established, and it's really a comparison between the new drug and the placebo is really the cornerstone of any trial on drugs, and it's widely accepted. Now, when you go to the concept, you are asking me why, if the patient is not able to consent, we should take the risk for him to be randomized to the control group or to the placebo group, which basically is the same. You have to know that the concept of direct benefit which could be necessary for accepting to enter a trial, has been challenged in most countries, especially in the U.S., who never accepted that concept and never put it in their law. Because they say that all the concept of research is not to give some benefit to the individual patient they recruit in their trials. The goal, the aim of research is to generate knowledge and not to treat that specific patient. It's why, despite it was initially that concept in the Helsinki Declaration, it was withdrawn in 2000, and it was never, it did not appear in the Directive 2001. Because if you ask a patient to participate in a trial, you cannot promise him any benefit, as that concept of direct benefit of research seems to indicate. You cannot promise that. It would be a lie, because, of course, you don't know the answer before the trial is finished. You know the answer only at the end of the trial, not before. If you knew the answer, if you knew that the new drug was beneficial, it would be unethical to do the trial. And so it's a difficult problem, because in some European countries, that concept of direct benefit of research is still there, like Germany. And I've been told by my German colleagues that until now, they cannot do emergency trials because of that problem of placebo, because one arm of the research would not benefit to the patient. And I can tell you that the appearance of that direct benefit for emergency research in the regulation has been imposed during the drafting of the legislation by some countries. Because if you go to the initial draft of the regulation proposed by the Commission, and as it was voted by the Parliament, that concept did not exist. And it has been added during the final trialogue by the Council of State Members, because some State Members lobbied to add that concept. And I can tell you that it was the more difficult concept which was discussed until the very end of the trialogue. So I don't know what you can. I don't know what will happen, honestly, because let's see. For France, we had that concept of benefit of research until 2004, and it was withdrawn because the directive did not mention that. So I don't see how it could be now reintroduced in our legislations. So I have no good answer for that. Probably it will depend on any interpretation by state members. Probably Germany will continue to refuse those trials, and I hope France and the UK will continue to accept the waiver of consent for emergency research.
Thank you, François. You also highlight the fact that although this legislation creates a lot of clarity, there will always be situations that cannot be resolved in law. I would personally think that maybe a big difference is whether it is indeed placebo or placebo on top of standard therapy. I would feel much more comfortable if the control arm was standard therapy plus placebo. Yeah. That I think is different. But indeed, we have a bit of an obsession to go versus placebo as nothing. And I think increasingly that will no longer be the case for many studies anyway.
Yes, I agree with that. When I mean placebo, but it is the same problem with the control arm
with standard treatment. Concerning the benefit, it's the same. But as you know, it's nearly impossible now to build a protocol with a placebo instead of the usual treatment. It's not possible. If you oblige a patient to have a washout of his usual treatment, to stop it and to start from scratch, I think now it's not acceptable. Ethically, I mean, it's against the concept of equipoise, but because one arm is not acceptable.
Yeah, thank you very much. So Florian, to answer the last question you raised, it's not a 3-arm study with placebo as nothing, standard or new drug. It is standard for all the patients, and add on top of that either placebo or the new drug. That's the point that François reached, which means that the individual benefit of the patient is always guaranteed to the standard level, and there can be an additional benefit for the new drug. Is that correct, François?
Yes, it is.
Okay, excellent. There's another question which just came in from Richard, England. Maybe Richard from England, I don't know. Richard, is there a difference between persons authorized to provide consent for emergency standard of care medical treatment versus emergency research medical care?
Can you repeat? It's a bit confusing. Can you repeat the question?
The question is if it's the same people who can authorize emergency care, like, for example, in your case, the 60-year-old comes into the emergency ward and is given standard care. Is there a consent needed for that? And if so, is that the same person who would also consent emergency research care? Standard of care versus research.
Yeah, it's a problem of should the primary physician be the investigator? Ideally, it should be better if the investigator were not in charge of the patient, emergency or not. But in reality, in fact, this is always the physician in charge of the patients who do research and do have the consent. But I know there is some proposal that those people should be different ones. I mean, the researcher should come, do research, but independently of the physician in charge of the patient. But it's, again, a bit theoretical, I think.
Yeah, okay. Thank you very much. I see no question at this time on the chat. I'm asking Adriana or Joan if you have a question.
Hello, this is Joan.
Yeah.
Hello.
Different person to provide the consent. There is a little specificity for children where the consent is to be made by the parents. I'm not sure maybe that this is the rule for the clinical trial. Do you consider that it's the same even in case of medical treatment and emergency not trials?
What is the question? Is it the same?
The question is that in case of trials, to give consent for enter children in a trial, we need the consent of both the parents.
Yeah.
My question is the same in case of current emergency treatment, not experimental? Do you need both the parents or not?
The parents, but for emergency, you mean? I must say it's not specified. It's a good question, but I've never heard about that. During emergency, it's not said that if it is different for children. So I cannot answer that.
Okay, this includes also the case of neonates, of course.
Okay, but I don't know neonates at all. But for adults, one consent is enough. We don't need to have several people. But I know for children it's different. But in an emergency, I cannot tell you. It's a good question. I must say I don't know the answer.
I do, so we are in the same position.
Okay, great. Thank you very much, Adriana. I'm back on the line. Joan, you also have a question?
Yes, I do. Well, first of all, I'd just like to make a comment about the placebo that Francois talked about. That was very interesting because I also thought that a placebo was nothing. So that's very interesting.
Yeah. So maybe, and this was also a remark in the chat. Maybe for the final slides, it would be good if we could change the slide to mention specifically placebo that it is placebo plus standard of care versus standard of care plus new therapy, because indeed people will see these slides that may otherwise have the same confusion.
Yeah, it just seems a lot fairer.
Yeah, right, but it's a sum up of many trials. Probably some with placebo, there's some others with no. So it's difficult to specify, I think.
Yeah. And it's Francois, as well, something that you said that really interested me was how different, for example, in the US and the States, how different like the concept of direct benefit is and how other countries vary in this difficult decision. Yeah.
But I think concerning Germany, it's really special because of the special history of Germany. And I've been told that necessity of providing benefit in research is written in the German fundamental law. And so it's very difficult to change, apparently, even if the global consensus on that point is changing, apparently.
So the standard rule is that the country, the national law, wins out over EU?
Yeah.
Okay.
If it is more strict, right, the EU sets the minimum, and you can be more strict. As a country, you cannot, I believe, be less strict than a regulation.
Yeah, absolutely.
That's
important.
Yes. The UK accepted that. Initially, the UK did not have that specific waiver of consent for emergency, and it was accepted only in 2005. So it's quite recent, you know. That concept is not so easy to accept.
Okay.
Yeah. Thank you. Yes, very interesting.
Let me turn again to the audience on the phone or online. Do you have any further questions? If you can't speak, feel free to type it in. We'll gladly raise it. We have about 10 more minutes, but if we have no more questions, of course, we will not drag it to get to that point. We want to be relevant to you. While you're thinking about that, any further question, Joan, or
I have another
Adriana?
question, Loda.
Please.
It's about just about partially incapacitated. If Francois could tell us a bit more about the difference.
So it was slide 4 of your presentation, Francois. There was the notion of partially incapacitated. Could you perhaps explain that a bit further? What is the difference between partially and fully?
Partially. I mean that you're not always in a deep coma, you know. You may have some, let's say, if you are stressed, for instance, your conscience is not perfectly adequate. You can answer some simple questions, but you're not fully competent. And so, in this case, I repeat, as in children, if there is some part of competence, you should make the patient, the participant, acting for himself also partially. But as was said before, if the patient says no and the person responsible for him saying yes,
I can't imagine what the investigator could do. So that's why I said to me it sounds a bit theoretical. Because at the end of it, you have to say, yes, I start the trial, and if a patient is not fully competent, it's really difficult to deal with him. You have the impression that you're waiting. You know what I mean? I mean you are forcing, and so it's much more. It's much better to deal with the person responsible for him. And in my experience, this representative, the legal representative, is usually much more concerned than the patient themselves. In many cases, those representatives say no. But when the patient after that is awake, he says, you should have done it. So it's more protective for the patient, I think, instead of trying to understand what he really wants or what he really says.
Okay, thank
so
you.
For me, don't use too much that provision. I think it's dangerous. For the patient, I mean, not for the trial.
Good, excellent. François, I also have a question for you. I know that you are, and from your perspective of being advisor to the French government of implementing law, one of the things that we struggle with in global studies or European studies as sponsors is how each country still ends up doing it slightly differently, even in case of a regulation, which of course is meant to be the same everywhere. So is there any effort that is being undertaken directly between countries to actually minimize the discrepancies?
I'm afraid not. If you are aware of the way the regulation is implemented in different countries, you see the main concern is which body will evaluate the methodology of trials. Will it be, as it is the case currently in most countries probably, the ethics committees, or will it be the drug agency as the competent authority? This is a major issue which has been raised by the regulation, because the regulation doesn't make an obligation to give that evaluation to the competent authority, but it suggested. And at that point, nobody knows exactly what will happen in the different countries. And this is a good example where there is no effort to coordinate actions of the different member states. I don't see any improvement in that situation, you know. And as I told, I was implicated in the drafting of the regulation. And when I was on the side of the parliament, and when I saw what was done by the council of the 28 member states, I was disappointed that it was so difficult for them to have a common proposal, a common position. So in that case, I'm not certain we go in the good way.
No, well, it's a very clear answer. It's a bit sad from a patient perspective, but it's clear. So thank you very much for that answer. Is there anything else? I have no more questions online. We are coming towards the end. Joanna, Adriana, do you have any further burning questions?
No, thank you.
Okay, good. Adriana, you or not?
No, thanks.
Excellent. Well, then, thank you again for really a very thought-provoking presentation. I would like to thank everybody for the questions and for staying online till the end, which really appreciated. Again, a big thank you to the speakers. And remember that indeed the slides of this presentation as well as the audio of the presentation part will be available as of next week, Tuesday, online. And with that, I would like to wish everybody a very pleasant evening, and thank you for having joined this webinar by EUPATI. Thank you.
Thank you.
Thank you, Luna, and all speakers.
Bye-bye.
And gentlemen, that concludes your conference call for today. You may now disconnect. Thank you for joining, and enjoy the rest of the evening.
Thank you. Bye.